and clinical policies, procedures, training for the CPI, which we'll do at the end of these sessions, probably at session 5. But as you know, you'll be going into clinic, and when you go into clinic, it's very different from when you're in the school setting. And the evaluation that you'll be looking at, as well as chart reviews, are very different from what you're doing right now. And hopefully we're going to hear these next few weeks based on what we're learning in class. However, there's not, when you have a clinical, when you're in a clinical setting and you have a clinical instructor who instructs you to read the chart or to come up with some kind of a plan of care or assist them in test and measurements, you may not always be familiar with some of the terms as well as some of the pathology. So, as Kevin has told you in the past, I believe last semester we were discussing it, Kevin had said there's times when you go, or I don't know if you said it with this class or with the other class, but there are times.
I usually say it at some point with people ask me, but I don't know if I told them. But yeah, I mean, like when students ask me, like, how do you know things? You just got to look at, you got to Google it ahead of time. You know, you try and look at your patient's chart, like before you meet with them, you know, ideally, especially if it's a new patient. And there are a lot of things that I don't either remember or I don't remember the terminology. And so, you know, you look on Google to remind yourself, right?
And that's one of the reasons why we had we were lucky enough to get them for you, those sliding muscle ruler things, because we understand that you don't know or don't remember, not that you don't know, that you don't remember all the muscles, origins, tertiary factors, innervation. And generally what we do is we do test you. That's a little bit different this year too, because of what's gone on and you know, I mean, it's unprecedented. So things are just going to be a little bit different. We also have, as I said in class the other day, scheduled open lab time during the semester, which you guys need to sign up for. This year, again, it's going to be different because we're limiting the time that we're on campus. And we were able, thankfully, to get on campus this semester, as you guys know, with labs and lectures. So I thank administration for that, because they did approve it and we were able to be on campus, which is a lot easier. As you saw the other day, it's a lot better, I think, for the psychomotor aspect to be on campus and actually do the practical application of labs in person. Although, you know, we did the best we could last semester. So this semester, though, is just so much harder, because this semester we're going to be going over in 102, which is this part of modalities. And modalities as well as gait training, and gait training observational gait analysis, instrumental gait analysis, manual muscle testing, goniometry, emergency situations, let's see.
You covered most of that.
Yeah,
most of the big ones. Yep.
Yeah. So, and then we throw some things incidentally in between. We also try to do interdisciplinary training with nursing. So that's something that I don't know we'll be able to schedule this semester. We're going to try to get the students up to the nursing department to do, when we talk about wounds, and we talk about wound care, and we talk about CPE, usually, and also later on in the semester when we talk about things like lines and simulation, like simulation mannequins. We don't have them in the department, so we bring you up to the nursing department and we're able to do something like that there. Even a transfer technique with a mannequin as opposed to a transfer technique with one of you guys, because the mannequins are dead weight. So blood pressure, heart sounds, breath sounds. You can do that stuff with simulation mannequins. But today, I think what we'll do is we'll look at Kevin had just sent you 2 questions, right, Kev?
Yeah, and let me actually, I can share it with you too, Dr. Stutz, if you want. It's right here.
Is that you, Devin, making noise?
I don't think so. I don't think I'm making noise.
Oh.
No, it would be me. I'm the only one who's unmuted here, so.
That's a nice kitchen, Devin. That's your kitchen?
That's not my kitchen. I'm dog sitting, so that's my aunt's kitchen.
Oh, that's very nice.
Yeah. It's like the size of my apartment, or an apartment.
Okay.
Yeah, so I have the Google document. I shared it. I shared the first 2 questions with all of you guys. So, you should see something that kind of looks like this. So we got 2 questions, right? Question number 1, question number 2, like, or case study number 2. So, we put this together, Dr. Stutz put this together because this is the kind of thing that you'll see, when you go into clinic. It's obviously not a Google document. I know a lot of you guys work in clinics, so like, what are some of the softwares that your clinics have used?
Like clinician.
Have any? Right, so you guys, like WebPT is one of them, and there are like a bunch of other ones, but once you use one electronic one, there's a lot of similarities between the others, and usually, the difference between, even if it's not exactly the same, like, there's gonna be a page where you get, like, the past medical history, right? There's a page or a tab or something where they have the medications. And, depending on who the therapist is and how well and how hopefully they take detailed notes, especially when you're seeing your patient the first time, because they'll give you things like the environment that your patient lives in. What are they getting going back home to? What are some things you need to keep in mind? As well as, a tab for the actual results of the, initial evaluation. So, we are just putting in these kinds of questions together, and yes, it's a lot to look at when you see it as a block, but we tried to separate it out and keep it a little organized. And what our goal for today is, we're imagining that this is your first day in clinic, or, I don't know, first month in clinic, right? And this is your patient, that in that document that you have, right? So, your CI comes to you and says, hey, I want you to deal with Mr. So-and-so in about 20 minutes. Here's the chart. Take a look at it. I want you to come up with, a plan of care, or whatever the questions we added at the bottom of the scenario. Those are the things, like, you could imagine that your CI asks you to do, right? And so what we're going to have you guys do for today is actually imagine, like, simulate this situation. Like, of course, it's not in person. So really what you're going to do is, like, for example, we want you to come up with a list of what are the major problems for our first patient, right? After you read everything, like, what are the major problems, right? What are the types of impairments? And if you can see here, there are different types of impairments, like direct impairments, indirect impairments, composite impairments. If that's something that you guys don't know, which is, it's okay, if you don't know what those definitions are, what do you think you could use to help you figure out what the difference between a direct impairment is and a composite impairment is?
Besides Google.
Oh yeah, you can use Google.
You have books, right?
You got the books, hopefully.
The books
right?
you can mess with, and you be able to look things up in books. Patient care book has some things in it regarding some things that we're going to be going over. Sullivan's book has a lot of information in it. There's a lot of different books out there, and some of you have books from other people or books from your clinic. This information can be found anywhere. And, of course, Google.
Right. So Google is good in an emergency situation. However,
in clinics.
Yeah, but not every search result that you first get in Google might be relevant, right? So a better source, if you have time, and like, this is one of those moments where ideally some of you guys should have the books. Like, if you have the opportunity, try and use an actual PT book, because they'll give you the pertinent, actual, relevant definition. Like, you want to always take whatever you get from Google with a grain of salt, because like Google is just a general search engine. So, like you could go to a PT website, but then you got to trust that the person who wrote whatever post it is actually knew what they were talking about. So again, use Google as a last resort, but when you have the opportunity, also try and use the actual, PT textbooks or whatever, because those are peer-reviewed sources that you can take as like gospel, basically, right? So Dr. Stutz, I guess if we want to do this, should we kind of, we'll split them into groups and have them take a couple minutes to read the situation?
Well, they're going to have to take more than a couple minutes. I think it's like with anything else. It's the first time you're looking at something like this. And as Kevin said, sometimes you get thrown into a situation where that the clinician expects you to do a chart review. Now, a chart review not only includes this information, but it also includes information regarding what else is going on with this patient. Like the doctor's notes, so the physician's notes are in there, the physician's orders are in there, the nurse's notes are in there, the nurse's orders are in there, pharmacy, special tests, social services, nutrition. It's all involved in a chart review. And sometimes, I think the most difficult thing, correct me if I'm wrong, Jeff, but you were at school, I was at a school a lot longer than you've been. But when you get thrown into a situation where, especially when you're in a acute care facility or where you have to review a chart, sometimes it takes an hour or more to just review the chart, and you have to do that prior to seeing the patient.
Yeah, it's really critical, especially when you're in like hospitals where, we were never told that we needed to come in early, but you learn very quickly when you're in clinic at a hospital, you need to come in early because you don't know what the situation is with your patients, and you got to be familiar with your patients, So yeah, like almost every therapist that I knew of who, even if they were scheduled to come in at 8 to start working, they were usually there by like 7. Or like minimum, because they would go through all of the patients they had today. They would pull charts. They would make sure they knew what they needed to keep track of for each patient. And when you start going in there on your clinical, this is your first time. So your CI is not going to expect you to do that for every patient, but your CI might very well say, "Hey, I want you to deal with this patient that we're seeing today. This is your only patient that you got to worry about, and so you're going to need to take the time to look at that chart." And your CI will give you enough time to look at it, but then your CI is going to say, "Okay, what are some things we want to do? What do you think of their rehabilitation prognosis? What do you think we should do? What are some goals that we should try and reach?"
Right. And the other thing that you have to understand is that there's a lot of words that you're going to see thrown into these scenarios that you don't know. Like when Kevin just said, "What is your rehabilitation prognosis?" So what is the prognosis? What's the difference between that and evaluation? What's the difference between that and something that you want to, some social context that the patient is having difficulty with? Like, there's a lot associated with what we're asking you in these questions and the information that we're providing you. So we'd like to break you up into groups. And what Kevin and I will do is we'll go into guide discussions into these groups. But you all have to, how many people do we have here today? I know some people contacted me. There's nobody in the waiting room, is there, Kev?
No.
Okay.
We have 18 people, including you and I. So we have 16 people.
Really? Oh, so there are people that aren't here that haven't contacted.
Yeah.
Okay. All right. So we'll break up maybe into four groups of 4.
Yeah.
All right.
That works.
So can you put them in breakout rooms, and then we'll just.
I don't have the ability to do that. You would have to do that, Dr. Stutz.
Okay. Breakout rooms.
one other thing, guys. I would probably say, since I think I shared this document with you, right? It'd probably be a good idea to first hit make a copy right over here and like make an actual copy for yourself instead of like everybody just writing on the same one document that I shared with you guys, right? So, make a copy and then you want to fill out whatever you guys are discussing with your groups for these questions.
You ready? And I'm going to do this randomly so that you don't say, oh, you assigned me with the same person all the time. I'm just going to do it randomly. So I'm going to assign you automatically. Okay?
Professor?
Yeah.
Kevin, how do you do that copy again? Or what?
Oh, yeah, I'll show you. Okay, so let me share the screen, right? You just go to File, and then you click Make a Copy. And then, you get to name it or whatever, and it'll open up in a tab for you.
Oh, okay.
You all good with that?
Yep.
Okay, so I'm going to assign you now.
Dr. Stutz, I'm going to join whatever breakout room you put me in, and then if you don't mind, just come back out here so I can ask you about something real quick. Okay.
Well, I'm going to move you, Kev, because you're in a breakout room just with 3 people. I'm going to put some other person.
All right, that's fine. I can actually not go into the breakout room yet, so.
Because there's only 3 people in one room. Who wants to talk about prioritized problems? Yeah.
I can give this a shot.
Okay.
All right. So the prioritized problems that need, at least from what I can get from our group discussion, was that the 2 key things we see is issues with the hip range of motion and possible strength issues. But the primary thing we find is balance being a problem because of a combination of her vision and her posture.
Anybody else? What are the impairments? What are the activity limitations? What are the participation restrictions?
So as far as the impairments, the direct impairments would include the actual fractured femur, as well as her vision problems. The direct impairments would include the leg length discrepancy, lack of range of motion, and strength.
Well, wouldn't the leg length discrepancy be a direct impairment? I mean, it's not something that happens secondary to something else. It was
we assumed it was secondary to the femoral fracture.
Is that what it said?
Let me find it real quick. Sorry. It's half-inch leg length shortening on right lower extremity.
It doesn't specify.
Doesn't specify. Okay. So
an indirect that I just noticed as well was that she has flexed hips and knees, so possible contractures.
Can it be a stiffness or a contraction? Could be either one, right? I mean,
yeah.
But when you looked at the range of motion, was the range of motion limited or did it start from 0?
Mm-hmm.
Yeah, so the range of motion.
Not.
Right? So if it was a contraction, would it say 0?
No, not for contracture.
Those of you who looked up normal range of motion of hip flexion, what did you find?
0 to 125.
0 to 125. Right. 0 to 125. So when it stated under what motions were for hip flexion, did it say 20 degrees to 145? And I know we haven't done range of motion. However, would it seem like it would be 0 if there was
not if it were.
Okay.
No.
So she may have the appearance, and I agree with you, Ashka, they may have the appearance or some tightness of the hip flexors because of what?
She's stooping forward. Her trunk is stooped forward.
Yeah.
Yes, so she's kyphonic, and she's stooping forward. Right?
Right.
Now, maybe that may be his, we don't know. That may be directly a result of the osteoporosis, maybe habitual gait, maybe secondary to unweighting that limb because as you stoop forward, you change the vertical gravity on the joint itself. We don't really know exactly what the cause of that is, right? Probably in this case, secondary to the osteoporosis. Thin, frail little lady, and most frail osteoporosis can happen anytime. It's very common in women that are smaller frames and thinner. So we have to worry about this. We also have to worry about the fact that she had this fracture. What type of fracture did she have? Kevin, you could, and anything I'm saying, just jump in anytime. What kind of fracture did she have?
Transcervical.
Transcervical intercapsular.
And I know in my group, and I'm sure in your group, Kevin, too, you looked this up and found it.
That it was a fracture to the femoral neck.
Okay.
Particularly surrounding the joint capsule of the hip.
So it's intracapsular within the capsule itself. And how do these occur? Anybody?
Sorry, you went out on me.
I said, how do these occur?
Oh, from possible slow motion falls. Any type of falling impact that doesn't cause a dislocation is what I've read up on. I don't know I remember seeing something else, but.
Okay, so in somebody like her, she said she was going upstairs, she fell outside the front door, that's what it says, right? She fell outside the front door.
Yeah.
So she would have to, she probably fell directly on it. She probably fell directly on it and fractured the femoral neck, not uncommon. Okay, it could also happen with the result of a twisting or a torsional motion. She's a light woman. She had an ORIF, right? ORIF, open reduction internal fixation. So we had discussed in our group that it could be she could have screws, she could have rods, she could have whatever, pins, anything to keep that hip together. And what are some problems that may be associated with the head of the femur or the neck of the femur or some intricate
Avascular necrosis.
avascular necrosis? Right. Not a big problem with this specific type of fracture, but note that avascular necrosis can occur. All right. I'm sorry, Kevin. I know you wanted to say something.
No, no, I didn't. Not really. You kind of in a flow, so it was good. I think, so we talked about the direct impairments, right? We mentioned some of the indirect impairments. And so just to establish for everyone, so what are some of the composite impairments?
The ADLs, such as, like, in this case, the inability to get in and out of the hub, I believe was mentioned, and issues with walking on the stairs.
Yes, but so this is Dr. Stutz. This was something that they were discussing in the group, and so I thought it would be good to discuss with you. In that kind of case, when we're talking about the tub, would that technically be more of a performance? What was the terminology? The performance qualifier versus composite impairment, or is it technically like a Venn diagram where it could be considered both?
It can be considered both.
Okay.
But when we're talking about the composite impairment, as we said in our group, does anybody want to take in our group that we talk to? What did we talk about when we said composite performance?
Balance was the thing that we hit on.
Okay.
Yeah, that was where we also came up with balance as well, just to follow Dan up.
Because who said 1 plus 1 equals 2? Marissa?
Cindy.
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 So we were kind of saying it was like pathology plus activity limitation equals composite, something like that.
Yeah, so we said that we had these impairments, these deviations or these losses, and then finally these activity limitations would really be the difficulty executing some kind of a task would be an activity limitation, right? Followed by some kind of participation restriction, which is more social. So that social component or participation restriction also involves the environment and social factors and the person. When we talked about the impairments, though, we said that the direct impairment, what does this person have? They really have like a visual problem, right? So if they have a visual problem, and when we walk and when we do things, what do we rely on? Systems, right? So we rely on a visual system, we rely on a vestibular system, and we also rely on proprioceptive system, right? So these are the things that we have to think about when we're performing just regular activities, getting up, standing, balancing, walking. So in this person that has this hip, one impairment leads to a secondary impairment, which would be more an indirect impairment. So in this person, we have this fracture with this pathology and this visual problem, which then leads to what? When we talk about the pathology, this disease, this fracture, this disease, leads to a decrease in range of motion, right?
Range of motion, strength loss.
Decreased range of motion, and you could see noted atrophy. You see range of motion, absolutely, Chris. You see range of motion loss, and wasn't that shown when you looked at physical therapy examination?
Yes.
Right? Okay. So when we put all these things together, and we also had a decrease in strength. No, albeit not so great, right? Because we looked at dorsiflexion and plantar flexion, I believe, and it was a 4 out of 5, which is pretty functional. I mean, it's more than functional. Of course, 3 out of 5 is actually functional. You need a grade of 3 to be able to stand up. So, putting these things together, let's look at the fact that she's got this pathology, she's got this visual problem, she's got this impaired range of motion, she's got this weakness, she's got this kyphosis, she's got this flexed posture, et cetera, et cetera. Let's put 1 plus 2 together, and what can we just name one thing that we can see as a result of a problem or an impairment? Balance, right? Standing balance. Whether it can be static balance, but can it be dynamic also?
Mm-hmm.
Yes.
What's the difference?
So dynamic is when you're moving and doing things in life, and the other one is just literally standing up.
Okay. What other factors do we need to think of when we think of dynamic balance? Let's hear from somebody who hasn't talked. What about Andrew? What about Isaiah? I don't hear you guys.
I'm sorry, what was the question was what was the result of the direct and indirect impairments?
What are you doing, Andrew? Are you with us?
I'm sorry, I couldn't really hear you.
You can't hear.
No, I didn't hear what you just said.
How are you listening to this if you can't hear us?
I didn't hear what you just said just now, sorry.
What I said was, what did I say? Oh, I said, how do environmental factors affect these composite limitations?
So we kind of talked about, it mentions in the description kind of the setup of her house.
No, I'm talking about environment. That must be a question, not your house.
Oh, environment. So maybe uneven surfaces that she's walking on, if she's walking up or down a hill, if she's walking on an uneven sidewalk.
Even more than that, it's environment. And if we're talking about ambulation and we're talking about dynamic ambulation, or even static balance, or dynamic balance, or dynamic ambulation, what do we have to pay attention to within the environment? What environmental constraints can be associated with this state?
Depending on how dark it is where she's walking, if she can't see well, her balance might be thrown off.
Okay. What else? Come on, guys. The guys that were in my group, we discussed this. You can start
What about
talking.
the dog?
While walking
Dog.
Did you say a dog, Chris?
Yes.
The dog, yeah.
What about a dog?
Well, I mean, it did say that she had the dog at the time of the accident, and the dog is less than a year old, which means it probably has a ton of energy and is pulling her around. She's only 98 pounds, so realistically, that could be a major contributing factor as to why she hurt herself.
Let me ask you guys this. Can any animal, can any person, can any car, can any inanimate or animate object present an obstacle?
Yes.
Yes.
Yeah.
Sure. Right? So when I asked you about environmental constraints, what I wanted you to think more of is, do you walk, when you walk, well, maybe now, you walk outside because I walk outside and there's nobody around, or I walk in the park or something like that. But normally, when you go you go to malls, Christmas time, you went to a mall. Maybe it wasn't the same way that it was in years past. Well, what happened?
You have to navigate around other people.
Right.
Yeah, you're playing
Odds like oncoming traffic.
playing Frogger.
Yeah.
It can become overwhelming for someone. You've never been in this situation, or a lot of you are very young, so if you've had crutches or you've had an impairment of some sort, or direct or indirect impairment, maybe you don't feel the effect. This woman is 78 years old, right? She has to go out into the environment. These environmental constraints are people. It's noise. It's dogs. It's cats. It's things running in front of you. You see that commercial for, is it osteoporosis? There's a commercial on TV about a woman doing great, and then she's on a ladder getting something out of her kitchen cabinet, and her grandson runs by and hits the ladder. I mean, there's all these commercials on, like, for osteoporosis. These are all environmental things that can occur that we don't really have control over, right? So these are some of the composite impaired things that she can have, which is standing balance problems, dynamic balance problems, ambulation, right? So these are some of the things that we might think about. Okay?
Could weather affect that too? You know how like for osteoporosis or osteoarthritis, they get stiffer when it's cold outside or when it's raining outside. Is that something that we should consider too?
What do you think, Jeff? You want to take that one?
Well, I mean, I would ask. I'm turning it back to Cindy. What do you think? Do you think that would be a factor or not?
I mean, I would think yes, but I don't really know if it's true. If there's truth to that.
Well, okay, so the question is, what do you mean by true?
Like, yes, you know how like sometimes they say that, cold weather can get you, what's that pulmonary disease? Like when it's cold, you get sick, right?
Yeah.
Is that something within that osteoporosis thing too, where like when it's cold outside, you get really, really stiff? Yes, we can feel it that way, but is it really that's the cause of that? Like, physiologically, is it the true reason why you're getting stiff? Is it the cold weather?
So whether or not it actually causes physiological changes, if your patient thinks that it makes them more stiff and they perceive more pain, does it matter whether it actually causes something, or does it matter that they feel more stiff and they feel more pain?
I guess subjectively, right? Yeah.
Right.
Yeah, psychosomatic.
Right. So this is one of those cases where, if someone feels stiffer in colder weather, which I can tell you, I've worked with a bunch of elderly patients, they hate coming to the clinic in the winter in the early morning when it's really cold. They'll usually come in around noon or whatever, because they don't want to be out in the cold. So is that a factor? Yeah, of course. That's a big factor. That is another environmental factor. Like, are they expected to be able to walk outside under the ice, or snow or whatever? So yeah, that is something to be thinking about when you're dealing with this patient.
Doesn't it also physiologically cause some sort of barometric doesn't barometric pressure changer and the pressure change within the joint have something to do with each other? Isn't it, there's a relationship between the two?
Yeah, there is.
Yeah.
So physiologically it changes the pressure between, when air pressure changes, the pressure within the joint changes.
Yeah, that's the strong theory. I don't know whether they've conclusively actually said, but that's what it leans towards. And enough of my patients have said it that I'm like, all right, I'm not gonna doubt that all of these patients that are all kind of reporting it. At this point, it doesn't matter if it causes it or not. They believe it. So, as far as they're concerned, it causes an issue.
We also talked a little bit about how with these environmental factors, but also the impairment imbalance, they're going to need to rely a little bit more on their proprioceptive input and how they need to really feel out their space, especially if she has vision issues as well. Going somewhere, she needs to understand, where am I in this time and space and what's going on around me to really be able to function and move, which is not an easy task to complete.
Right.
Takes a lot of sensory understanding.
Sure. And it involves thinking about things that you don't really, if she needs to go to the store by herself to pick up things, and she usually likes to go on a weekend in the afternoon or something, you might have to say, hey, maybe we want you to go on a Monday, in the middle of the day or something where there aren't as many, and there are a lot of times where patients are like, oh, I never thought of that. I never thought I need to do that, but that's the kind of thing that you want to be aware of because you know that this patient has these issues. So you want to yeah. Yeah.
So what are her, just to get back, what are her activity limitations? Does she have any?
She can go up and down very well.
Walking your dog?
Is that an activity limitation?
Participation. Yeah.
What running?
It's more of participation restriction, absolutely. The fact that she's not able to walk her dog. Right.
Her activity limitation, she's partial weight bearing, so she's not supposed to put full weight on her operated leg.
Okay, is she able to get in and out of a tub?
No.
Not without assistance.
And
Stairs should be
yeah, she needs minimal assistance. That's an assistance for homemakers.
It's an armrest or something like that, like a guardrail.
Okay, now she has a tub, and we assumed right earlier that since she has femoral neck fracture that there was some precautions, yeah?
Yeah.
So can she get in the tub?
No, she shouldn't be flexing too much.
Right.
So would she be required to have any kind of an assistive device?
Shower chair.
Right?
Or even a raised toilet seat if her toilet seat is really low.
Okay. What other participant limitations does she have when we think about her history?
Driving.
Can garden, can drive.
Well, would gardening and driving be an activity limitation or a participation?
Participation restriction.
Participation restriction. Okay. So, is she able to perform all her home activities?
No.
So that would be an activity limitation, right? And as far as stairs are concerned, is she independent? Is she dependent?
Stairs, I think she's independent, but she needs a small base quad cane.
Okay. So she needs some kind of assistive device.
Yes.
That could be a limitation, right?
And hold on, it didn't just say small base quad cane, it mentioned something else too.
Oh, with the rail.
Walker.
With the rail. And does she have rails on every door of her house or stairs of her house?
No.
No, on the front.
No, right? So that's an important, like, you can't just say small base quad cane. It was small base quad cane with the rail, right? And she also doesn't have a lot of rails in certain areas, so you have to be aware of that. That's, you know, you haven't covered gait yet, but, you know, you'll see and feel how hard it is to do it one way or another with certain assistive devices. So.
With or without a rail makes a big thing. Big difference.
Yeah. And she also has, it mentions she has 2 rails on her second flight of stairs, but another thing to consider is if they're close enough for her to hold both of them and go up, or if they're far apart, where she does need an assistive device to go up that second flight of stairs.
Right. And we already discussed her participation restrictions. So participation restrictions would be, she can't attend that garden club, didn't she go to a garden club?
Yes.
Yeah.
Right? So she can't attend that, she can't go to the senior center, right? So these are some restrictions that she may have that really may affect her psychologically. You know, she can't walk her dog anymore, she may have to pay for somebody to do that. So these are all restrictions associated with what's going on with this patient right now. Okay.
So is it safe to assume that participation restrictions would be just like the leisure activities that you're doing and not really your activities of daily living, you know?
It's kind of like a quality of life thing.
Okay.
It's like it's not the essential parts of the patient's life, but it's the parts of their life that, like, you know, gives them enjoyment and it's important for their mental health.
Okay.
Can I give an example real quick?
Yeah.
So I just had contracted COVID and I was isolated for 12 days. And one of the hardest parts about being quarantined is the quarantine itself, because I had to have my food delivered for groceries, all that. And it actually affected me, like, psychosomatically. Like I was like, oh, I'm incapable of doing my daily things. Like, I normally food shop and I know exactly where to go, but now I have to wait on people. And there was that effect involved. Now, obviously, it's not a physical limitation, but because I was required to, and that's, you know, that's
and you know, but you saw how that affected you, and that was only for 2 weeks, right? Yeah. And you were physically able to move around. Now, this is an older woman who was independent, who now just lost a lot of her functional ability. You know, she's probably doubting whether she might even be able to do this kind of stuff again. So, you know, you can't neglect the emotional support. Like, a lot of the therapy that you do as a therapist is actually the emotional bit. You know, being able to assess, can you get them better? And maybe you can't get them 100%. So, I mean, you know, you don't lie to your patient, but you say, hey, we can get you, like, as close as we can, and I'll help you. You know, and it's having someone say that to you, that is a huge part of, like, what your job is, right? Given that emotional component. So you want to be aware of that kind of stuff. It's also helpful because, you know, it's how you help when it gets hard, because therapy is going to get hard at some point. It's how you get them to continue doing what they need to do. You know?
So, activity limitations is more like what we were talking about, getting in and out of the tub, climbing the stairs, difficulty ambulating.
Yeah.
That's activity limitations. Participation is more the social aspect.
It's the social, like, yeah. You know, attending her book club, going to church, doing that, you know, like that kind of stuff.
Gotcha.
Yeah.
Okay, let's do number 2.
All right. Oh, you mean scenario 2?
Yeah.
I think my group only.
Question number 2.
Oh, question 2.
Question number 2.
Okay.
What information is available about her functional status within the home in terms of performance versus capacity qualifiers? So what's the performance qualifier?
things that they do in their own individual environment.
Okay. So what are some, so do they involve physical factors?
Yeah, so something like, in her case, like her walking a dog or her standing up and doing the dishes.
So we're talking about tasks or actions for this patient that are incorporated in her real life, right? So they impact some physical factors, some social factors, some her attitude, like you were just talking about, Casey, your attitude associated with being home. that will affect her performing her task or her what anything she needs to do in real life. So what are physical factors?
So some of her physical factors.
Right, as far as her house is concerned.
Yeah, so her climbing stairs, her
Not without the railings.
not without the railings. Her
Does she have something that goes into her living room too? Is it
Yeah, I mentioned there's a step.
Right?
There's like one step without a rail, I think.
Yeah.
Oh yeah.
So that may be something that's a problem.
And then there was another thing too.
Her
It was,
upstairs is also super cluttered with heavy
Yeah.
furniture.
yep.
Okay. Is her bathroom accessible?
Kind of, but not really.
Let's see.
Because the tub is really high,
And it's small.
and it's also on the second floor.
Second floor.
Right.
Okay, so her bedroom is on the second floor. Does she have a handrail going up the steps?
Yeah, there's rails
Yes.
on either side.
Okay, so she's got a full flight of stairs, but the bathroom is on the second floor. Okay. What do we know about this patient socially?
She lives alone, but her family's about an hour away.
Okay, is that close?
No.
No.
Okay, so she lives alone.
It was mentioned that she had an aide.
So she requires a home health aide, right? So those are some social factors. Does she have any problem with her attitude? Not really, right?
No, she's not pretty motivated.
Nothing that was mentioned. Okay. How about capacity qualifier? So, Casey, you talked about what a performance was. What's a capacity qualifier?
From what my understanding is what
You
they're.
don't have to answer. Somebody else can answer. You answered. You answered. Anybody else?
Yeah, an individual's ability to actually execute that task or action.
Okay.
So how able they are to do it.
And if they're able to do it, are they able to do it with anything? I mean, if they have an impairment or something, is there something that they use to perform that task with? So can they still do that function by use of some kind of assistance, right? So in this particular patient, what are they?
She has that small base quad cane.
Mm-hmm. Right. And then we mentioned something else. I forget who mentioned that she had somebody at home. Who else can help her? So in this particular case, those capacity qualifiers would be something like, just like you said, ambulation, that small base quad cane, as well as that home health aide to provide her assistance.
They also mentioned that she could ambulate with a standard walker times 200 feet on a level surface, but I'm not sure if this is at home or if this was during the evaluation.
Probably during the evaluation, because she was progressed to a short base quad cane, right? So in order, which do you think provides you more stability? A small base quad cane, or a walker?
A walker.
A walker.
Walker has got 4 feet, right? So it's going to provide you a lot more stability than one cane. Right? Okay. What's her rehabilitation prognosis? What do you think? What's the prognosis?
Basically, like what we expect to see, like her course of how rehab, like how she'll progress to rehab, or like what we think her outcomes are going to be.
Yeah, so it's kind of an estimated guess, right, of what's going to go on and how, I shouldn't say estimated guess, but that's what I want.
What you reasonably can expect.
Right.
That's better.
So Mel, what do you think?
I don't think she'll be able to gain full independent ambulation, but maybe with a more minimal assistive device, she could, but I don't think that she'll be able to independently walk by herself again.
No.
Yeah, I don't know. Well, I mean, like she's kind of got a lot going on. She's had a history of falls.
Well, hopefully by you working with her, you're gonna try and reduce the falls, right?
Yeah.
So
you know what it is? I think it's because I'm like more of a realist than an optimist.
don't tell your patient they're not gonna be able to walk again independently. That's not a good way.
I would tell her I would like to see her be as independent as possible. You know what I mean? I'm not gonna say like I don't think you're ever gonna walk again. Like
okay, so then what you say is, hey, we're gonna get you as independent as possible.
Right. Okay.
She says, does that mean do you think I can walk without a walker? You say, yeah, we'll see. We'll work towards that.
Right.
You know.
But that's the next question about expected outcomes and goals, right? So does anybody else think that she's got a really, really good prognosis?
Yeah, I don't see why she couldn't, eventually get back to being able to walk on her own. I mean, prior to this, it says she was fully functional by herself. And she's got a great attitude, and that's the biggest thing. Honestly, I think when you're dealing with patients, it's, I don't want to say 90%, but I would say more than half the battle is their attitude. If they're willing and they want to meet you, and they want to get better, that's, we can do it. We can make it work in most situations.
And that is the big thing. Like, she has the great attitude, which means she'll probably do what you ask her to do to get better, right? So take advantage of this patient's attitude, and she can do a lot of those safe things on her own, so you can do the hard stuff with her, right? So, yeah, definitely take advantage of that attitude for sure.
So we agree that she's got a pretty good prognosis, right?
Yes.
Yes.
I have a question in regards to prognosis. When we talk about prognosis, is the only option we can talk about it is like either they have a good prognosis or a bad prognosis?
No. I would never use the word bad. Because we don't say bad. We say it's poor, or it's excellent, or it's good, or it's fair, right? Those are the terminology that we use. I would say her prognosis is excellent.
Okay.
I would say her prognosis.
I wasn't sure about the scale of it, like if it's like good, or it's like okay, or if it's bad, but it makes sense.
I see what you're saying. So either it's poor, it's fair, it's good, it's excellent. But I would probably say that her prognosis is excellent based on what I'm reading in this. Of course, these are scenarios, but based on she gardens, she walks her dog, she wants to be active. She does all this stuff. She wants to return to that, right? Those are probably her goals, to return and do everything that she wanted to do before. Now, a lot of people have goals. Some people say, well, I want to play the piano. Well, you never played the piano before. That can't be a goal, if you have a hand problem. But I'm just, what I'm saying is she's done all these things before she wants to get back to doing these things. So her prognosis is excellent. All right, but what are two expected outcomes and goal statements directed that are associated with her plan of care?
So I'm assuming one of the outcomes is that she's able to ambulate with no assistance, without the small base quad cane, and that she will have strength and range of motion within functional limits of her right lower leg.
Okay, so you're saying she'd be safe in ambulation with this, independent and safe with the small base quad cane for household distances, let's say, right? Within how many weeks? So if we're going to base
6 weeks.
Expected outcomes, generally, if you saw this patient on an outpatient basis, and don't quote me on this because they may be different in different facilities, but sometimes we base short-term and longer-term goals on something or expectations on 4 weeks versus 8 weeks. And in the clinic, it might be, in the inpatient, it may be a little bit different, okay? So maybe within 4 weeks we expect that. Do we expect her, what else? Because I agree with you, Casey.
So, Professor, I have a question.
Of course you do.
Well, we're here. So our goals kind of like we were, are those similar to like, a goal statement would be like linked to the participation restrictions, whereas the outcomes are more about the activity limitations? Like if she has a limitation in what she can do activity wise, an activity of daily living, an expected outcome, for example.
An expected outcome will be more reflective of an activity of daily living, yes.
Okay, and then a goal statement is I want to get back to walking my dog, gardening, etc.
Right.
Okay.
So a goal for this patient will be, as Casey stated, and I agree with him, the patient will be in independent ambulation with a short-based quarantine in 4 weeks for, let's say, around her house. You know, maybe in 8 weeks out in the environment and become a community ambulator. You know, something like that. Okay? So that would be a difference. How about she'll be independent in bathing, right? Bathing and grooming. So will she be independent in transfers, I should say, not bathing, but transferring herself in and out of the tub. Okay, so that may be a goal. What would she need? If, like we said before, this person may need some kind of an assistive device as opposed to, not as opposed to, but a shower chair. And then if she's in a bath, if she's in a tub, and she has a shower chair, what would she need in order to wash herself?
To the chair.
What would she need? And this is not, I'm just throwing this in here right now, but what would she need?
Like a rail.
What do you think, Andrew? Because I want to make sure you can still hear me there. What do you think? See, when I don't see you guys, and I don't hear you, I hear Chris, because we always hear Chris.
She needs her kids. She needs to ask her kids to run.
No, we need Andrew to talk. We need Andrew to talk. Andrew, what else does she need? She's sitting there in that tub. She's got that shower chair. What else does she need?
Maybe a handrail?
Handrail in a tub?
Yeah.
Yeah. You mean somebody's gonna come in? She's gonna call Andrew Levine. He's a handyman on the spot. Put that.
I wouldn't trust me with that, but.
Put that metal thing on the wall so that you can hold onto it and get up. What if she doesn't have that?
So she has this.
Get one of those removable.
Some of these chairs come with, what do you call this, Kevin? The
handrest?
The armrest. Yeah, so you make sure that she has that. But even as far as washing, she's sitting in a tub. She's sitting in a tub.
Maybe like a brush with a long neck.
Like one loofahs or something with like.
What about that retractable, like that shower? You know, like the thing you connect to the faucet so that she can move, like the.
Oh, okay.
The shower handle.
See, you guys are all thinking, I'm going to hop in the shower and I'm just going to hop it, right? Well, yes, I agree. I mean, certainly what you need to do is you need a handled brush, like Tyler said. And then who was it? Marissa, I believe, or Melissa? Melby?
Melissa, yeah.
Okay, so you talked about the fact that you need a nozzle and you need what is it?
A shower wand.
It's like
Shower extension or something like that. Those are all the things that you need to think about for this patient. All right? Mm-hmm. Oh, this is very different than just total hip replacement contraindications, right?
Right. You also need to ask her kids to renovate her bathroom overall.
Either kids, what do you have? A 2-year-old and a 1-year-old? What are they going to do? They're going to become obstacles in your gait pattern. So they're going to be environmental constraints that you have to consider while you get home. So well, these are all the things that you have to think about when you're sending this patient home. You know, a lot of therapists, I mean, much more now than ever, but when I was in school, you know, you rehab somebody, you got them out, you got them home. Very rarely did you think about the fact that what's going to happen when they get home. You know, what's going to happen? All right, so let's see. 2 treatment interventions? All right, now I know Andrew can give us some treatment interventions because Andrew is the treatment expert. Are you there?
Sorry, I was muted. You said 2 treatment interventions?
Yes. I just want to make sure you're not walking away and ignoring me.
Oh no, I'm here. So I'm trying to think of what we didn't really go over what that entailed, but
What do you think?
is that like things that we're basically things that we're going to do with her to help improve certain things?
Yeah, let's say it's like 6 months, 6 weeks after, 12 weeks after after she's out of the hospital. And you're kind of going in as the home care therapist, which you can do in New Jersey now, right? New Jersey, I think it's legal. You can do home care. So you go and you do home care. What do you want to do with her? What do you think should be done? Good things that you could do.
Definitely some degree of like balance or vestibular training.
Okay. Any particular strengthening exercises initially?
Like baseline strengthening exercises, hip strengthening, glute medius, glute maximus, just to help, with that foundational kind of hip stability and strength.
Now, she's going to do a lot of functional activities like get up.
Okay, so we could start with like some sit to stand off of a chair.
Okay, that's later on, right? Because Devin had talked about, which I agree later. So what we're talking about 12 weeks post-surgery, Devin, what would you offer her?
I'd start doing some weight shifts and like some proprioceptive balance training with her.
Yeah.
But initially start her off with like gradual weight shifts and progress to like a single leg stance. Probably do tandem and Romberg stances as well.
Right. You guys understand that? You agree with it?
Yes.
Yes. Yeah.
What are tandem and would you say, Devin?
Romberg. It's just like his feet together. Or no, it's Romberg. Romberg's feet together in tandem is one in front of another.
Oh yeah, right, okay, yes.
And some of that tandem walking you can also do, as long as you follow precautions. In this person's case, you wouldn't be able to do that braiding, but you can do braiding also, and those are things that you could have. What else can you do with this patient? In order
Couldn't you work on her posture?
Yeah, you can work on posture. You can work on her posture. But if this person had a difficulty, like sit to stand, or even weight bearing, or shifting weight, how could you provide her some things at home in which to assist her?
Isometric exercises.
Okay, so she did the isometric exercise. We talked about isometric quads, right? And in my group at least, Ashka, what's an isometric exercise?
Where you're contracting the muscle without lengthening or shortening it, like a glute set or a quad set. You're just kind of
so without shortening, and you're not seeing any visible contraction, right? So something like a quad set, a glute set, a ham set, right? Mm-hmm. Okay, but once you get her up and you want her to weight shift, you're not in the clinic anymore. You're not in the parallel bars anymore. How can you get her to weight shift? She's home.
Use a countertop, maybe?
Yeah. Use a countertop, use a sink, those kind of things. How do you get her to increase any range of motion that you want her to increase? At her hip?
Have her do marching or doing some sort of dynamic motion to the range of motion she feels comfortable, then slowly lower it. So like say if she's doing sit to stands, you're going to probably start her off on like a 2-3 inch pillow and then slowly decrease the size of the pillow.
Okay. So what else can she do against the counter to make sure that her gastrocs are strong? Her
heel raises.
Heel raises, right?
Heel raises,
yeah. So she could do heel raises. She could do toe ups. She could do some kind of a mini squat or a partial squat. Mm-hmm. And we could start her off in sit to stand. Now, sit to stand, if she can't sit-to-stand is difficult, right? I mean, not for you, but maybe for her, especially after what she's gone through. So what can you add to a chair to assist her with sit-to-stand?
Like a pillow.
Cool. Yeah.
Pillow and maybe have her do it on a chair that has handles.
Yeah. So the worst thing that you want to do with these patients is get them, because a lot of times these patients say, well, my husband has this chair where I push a button and it takes you up to standing. Is that a good thing?
No.
No, because it makes a person more dependent, right? So those are the things that we want to do. We want to work on weight shifts. We want to work on increasing stability with this patient. We want to increase strength. We want to increase range of motion. So if we wanted to increase range of motion with knee or hip, we could also place one leg on a stair and we could lean into it to increase the range of motion of the knee or increase the range of motion of the hip.
Well, she's also living at home with a dog too. You could also benefit from like small space navigation, like agility exercises. Just like basic stuff, nothing too fast, but something like working through like small boxes. But
what do you think of
that's just a thought.
Kevin's always thinking. He's always thinking about what are you going to do with the dog, though?
No, just like in the clinic. I mean, she needs to be able to move like efficiently through the house, right? So if we start to her ability to move through sequential patterns, like through agility ladders, like maybe she'll just more like, I don't know, just like she'll be more agile around her home.
Yeah, but you can never really predict the behavior of the dog. You can always tell her to go through these columns and ladders and kind of navigate her way through. But I mean, even in the excerpt here, it says she's a rambunctious 8-month-old puppy. And, one day he can be completely fine. Another day he can like pull her and just,
I'm standing by it.
So I mean, as a way,
I think it's super advanced though for the agility ladder for a 78-year-old woman.
Not necessarily.
Hill sprints.
So, Father, you eventually probably have her do, because she was limited in her hip flexor, so walking backwards while you're eventually probably, I don't know, while you're holding onto some.
Sure.
Like holding.
You can do all of that stuff. You have to be creative when you do home care, as opposed to, as Devin was saying, when you go into a clinic, you have these agility ladders and everything else. You don't have that when you go into home care. So you have to be creative and say, what is it that I need to do to help this person achieve the goal that I'm setting?
You can also work on step-ups using like a smaller step and then progress higher with levels. And, if you're doing home care, you can just practice on like the bottom step or that step she has in the landing between the kitchen.
Right. All right. What does TED stand for? Neil? I didn't hear from you. I've been picking on Andrew.
PEDS? It's a PED.
But Kevin was in your group. That's why I'm just grabbing you guys, because I talked to the guys in my group. What does TED stand for? What is TED? What is the TED stuff?
There's a TED?
Yeah.
Oh,
It's right here. Where's bilateral TEDs? QAM.
Unfortunately, I don't know that, so I'm sorry.
That's okay.
It's all right.
Anybody know what that is?
What's compression
socks?
Compression stockings, right? But what's the TED stand for?
Something thrombosis.
Thrombo and embolic urine hose.
How about thromboembolic deterrent stocking?
Thrombotic embolic.
Thromboembolic deterrent stocking. That's what it stands for. So what does it prevent?
Thrombosis.
Deep vein thrombosis and pulmonary embolisms.
Okay, hopefully it does. Yeah, hopefully it does. And there are certain, and when we talk about, because we will in the next couple of weeks, and we're going to try to associate what we do in clinic, in lecture for the week, and bring it over into Friday's discussion. But it's to prevent CBTs, right? And CBTs. And generally, you'll see TED stockings in when a patient is really in the acute phases. There's a difference in the millimeter of mercury and the compression associated with that. So the compression may need to be greater as they're ambulatory. But when they're in the hospital, in order to prevent CBTs, you wear TED stockings. What else do you do to prevent CBT? Because that goes into what precautions should be observed. So when we're talking about number 6, what precautions should be observed?
Well, I was asking the group before, and we couldn't really, or at least I was thinking that it would be similar to a hip replacement, but
okay, all right. So you're correct. You're correct. So we have hip precautions, right? And what are hip precautions? What are the hip precautions?
no adduction, no hip flexion past 90, no internal rotation.
Okay, so no flexion of, everybody good with that?
Yes.
Yeah. Remember that. Okay. So, that's another reason why when you think about what goes on at home and let's say this person doesn't have the money to get all the rehab that's required before they go. When we talk about ADLs and we talk about occupational therapy, or maybe an occupational therapist isn't there. Maybe they're at a different facility. Maybe they get released because it's 2 days of surgery and they get sent home. So then what do we have to think about what needs to be ordered for the patient and what kind of insurance? Because if they have Medicare, Medicare will pay for certain things. Now, Medicare may pay for a walker or pay for a tub seat and a walker, but maybe they won't pay for, where was I going with this? Two things that they may pay for a walker, they may pay for a wheelchair, but then if they pay for a wheelchair, maybe they don't pay for a tub seat. So, you have to understand where the patient's coming from, what the patient would require. So, the precautions associated with this patient, where was I going with this? I don't know what I said.
Precautions for the patient? Well, I mean, they mentioned hip, but there are other precautions because you mentioned...
You don't want her to sit still. Like, you don't want her to sit still for a long period of time.
Why not?
Because you want them to see, like, circulation.
Sure. So what other things could you do?
Ankle pumps.
Yeah.
Ankle pump, right. But before we even go there, the other thing I'm thinking about was the raised toilet seat. Don't forget that.
What?
A raised toilet seat but this person may need to do that. Remember, if we're following the precautions that we can't flex past 90 degrees, right?
Right.
Yeah.
Okay. So go ahead.
I was also thinking about like the interaction and the side effects of some of her medications. We looked up some of her medications, and some of the associated side effects were like dizziness, and like low blood pressure. So obviously this has effects on a lot of other stuff, but she just keeping in mind of what medication she is taking, making sure that she's taken them if she's coming to PT, so like her blood pressure doesn't increase or decrease, or she doesn't get dizzy out of nowhere. Yeah.
Right. That's something we didn't, I think we kind of glossed over. I know we did, at least in my group, we looked at medications a little bit, and one of the things we said was the patient was taking Fosamax. And why do you take Fosamax? Why was this patient taking Fosamax? For the osteoporosis, right? And what are the side effects associated with it?
One of them is joint pain and swelling, which I found interesting.
And and everybody doesn't get the side effects, right? But one of the things that may be associated with other things that she's taking is that there's, because she's taking Colace. And what does Colace do?
It's a stool softener.
Softener. And what is one of the side effects with Fosamax? Constipation. So she may be constipated and need stool softeners. What is What heart medication is she taking?
Atenolol.
Atenolol.
Right, which treats the high blood pressure, right?
Yeah.
As well as angina. And what's angina? Chest pain. And what is that? That's actually a beta blocker. When patients are on beta blockers, their blood pressure doesn't go up quickly. It elevates, it stabilizes the blood pressure. So you're concerned about, you want to make sure that, and this is well in advance, but you may want to use like a perceived exertion chart when you're working with this patient to know how much exertion they are putting on the heart. If you're not going to rely on vital signs such as blood pressure. Okay.
It also stated that she became short of breath with like 20 minutes of exercise. So just keeping that in mind as well.
Absolutely. Absolutely.
And then also she has a pacemaker, so maybe that could be another reason of her.
I mean, we would avoid stim.
Yeah.
Right.
Okay. All right. So finally,
She also wouldn't do any massage, right? Isn't that what we learned? Because she has osteoporosis. I don't know. You don't have.
well,
I don't think we would do massage, but it's not an aid with our in that.
is massage contraindicated with somebody who has osteoporosis?
No, it's for
For
someone who
heart.
has congestive heart failure.
Okay, right, heart.
Yes, osteoporosis is not contraindicated. But, if something is severely osteoporotic and the physician gives you an x-ray report that shows severe osteoporosis, you're not going to be aggressive manually. But I know in class the other day, at least in one group, we did a little, I guess it was your group, right, Devin? We did a little effleurage and a little, which felt good. We also did a little craniosacral. How did you feel after that?
That was wild. That was pretty cool.
Did you feel good?
Yeah, my head felt really light, like all day.
Okay, you owe me.
Okay. I don't have my copay today, I'm sorry.
All right, so finally,
I'm sorry. Should we be considering the way, or should we be mindful about how she sleeps at night too? The positioning of her legs, considering that,
Definitely.
her thrombosis and stuff.
what do you think, Chris?
It's getting up.
Oh, well, for the thrombosis, so we could have, wouldn't want her legs lower than the rest of her body at all, but most people wouldn't sleep like that anyway. But I was thinking more about the adduction of her one leg over the other one, and then internal rotation. So maybe having a pillow or two in between her legs if she's going to sleep on her side.
Right. So getting back to those precautions that we should observe, because we should observe some precautions. I think somebody brought them up already. Precautions.
Yeah, we went over them.
Isaiah, you have any? Blue?
I'm actually looking at we're still talking about the case questions, right?
Yeah.
Where you been?
I'm sorry. I had to do something. I had to talk to my parents about something with the whole situation before. So I was a little preoccupied for a second. I apologize.
What are the precautions that you can observe with these patients?
Let's see. I don't know. Probably like you mean environmental wise?
Any precautions at all? We had mentioned, and I started this off by saying what a TED stands for. So somebody spit something out when we talked about TEDs, right? And DVT. And what did we say for that? Anybody want to repeat that? Dan, you want to talk about that?
As far as
You want us to be sitting for a long period of time. You want there to be circulation.
You don't want to be sitting for a long period of time. What else do you want her to do with her foot?
Ankle pump.
Ankle pump.
Yeah, ankle pump. So you want to, and you also want to avoid no sitting for a long period of time, because what other systems can be involved? When we're talking about systems, what other system can be involved when you sit a long time? Pulmonary, right?
Respiratory.
What happens when you lie down in bed a long time and you don't move and you don't get up and you get secretions that aren't being able to expel properly? You can wind up with a person that has pneumonia. So this person can have pulmonary complications as well as vascular complications. Yeah?
Yeah.
So you also want to prevent this long time of immobility, because what does immobility do?
Contractions?
Those are contractions.
Besides contractions.
Blood clots.
So we can put pressure on bony landmark.
It certainly limits your range of motion. Yeah, I mean, you could develop pressure sores. Pressure sores, what else?
What about blood clots?
Absolutely. Yeah, so we talked about somebody can have a DVT, right? DVT. And functional training. And we're going to worry about the hip precautions, which we said we're going to do to avoid stress at that fracture site. And then I think in my group, I don't know whether it was Dan, it was somebody in my group that talked about, or maybe it was in your group, or maybe it was in Ashka's group. No, Ashka, you were with Dan. Maybe it was Devin's group. They talked about.
That was with Devin.
Okay.
I had Ashka, Kyle, and Rich.
And we talked about postural exercises. We also talked about what is her history? What's her history?
Would it be urinary incontinence too? Would we look at that as well or no?
Well,
was it when we said she has a history of falling?
Yes. Yes, she had a history of falling. So if she has a history of falling, what can we do?
Can we have her get up properly?
Do we do anything as therapists for fall?
Like show her how to get up properly?
Work on balance.
Yeah, do your clinic do any kind of a fall prevention program?
Mm-hmm.
Right? So maybe we need to address the history of fall. What else do we need to do in the home setting? Because if she's got a history of fall,
make sure that all the obstacles are removed and put in place, and if there's like narrowing spaces, kind of see if you can move furniture around to make that space a little bit bigger and easier to navigate.
Okay.
The lighting has to be appropriate, maybe night lights everywhere.
Right. And what else?
And then if in the case that she does fall and it's not severe, in therapy, teach her how to get up from a fall by herself using her surroundings.
Okay. What else?
Would also teaching them how to fall properly be something that you could teach?
Yeah, that's what Dan just said. But when we look at the environment, look around your own. Some of you have hardwood floors. Some of you have wall-to-wall carpeting, right?
Yeah.
So hardwood floors versus wall-to-wall carpeting. But those of you, people have bathrooms, people have things in their kitchen. What else can you see? You could see something like throw rugs, right?
Yes, right.
And some of these people even have rugs in their bathroom, right?
Yeah.
So you have to think about the fact that if you have a rug in the bathroom, is it a rug in the bathroom that is one that's just going to slide, or one that's going to have some kind of a backing to prevent friction, right?
Yeah, aren't there those bathroom ones where it's just it's the non-slip ones, where it's ripped?
But these are all the things that you have to think about when you think about this patient.
Proper footwear?
Proper footwear. Something that allows friction as they stand. Something that you won't slide. You need to have the appropriate footwear. In this person, maybe that can't bend because she's got initial precaution. What kind of sneakers are you going to tell her to get? Well, she asks you, what's the best sneakers to get? And do I need to get? I'm not talking about Nike or New Balance, or I'm not talking about the name of the sneaker, but
like a supportive
what kind of
sneaker.
Style of a sneaker?
Non-slip?
Something that slips on, something that has Velcro, right? So all of the things that you need to think about before this person goes out and purchases something. All right. Anything else? Any other precautions, Kevin, that you guys observed with your group?
I mean, he kind of mentioned almost basically everything that
Well,
they had.
something else could be like if she has an assistive device that it's always readily available for when she is ready to get up. Like if she's on the couch or if she's in her bed, it's always where she, like near where she needs to be.
Yeah. So that is a very good point. Yeah.
All right. I wanted to get to 2 questions today, but I guess we just didn't have the time. I hope this is this something that you would like to continue? I think this is helpful for.
Yeah.
Oh yeah, definitely.
Great.
Absolutely.
I'm just curious, when we get to the clinics, I mean, it did say that it's observation. Is it something that we basically would be shadowing, or is it something that we're allowed to be hands-on with the patients if our CIs?
It'll be different too, right? Because COVID as well.
Yes, and it's going to be. We don't know what's happening this semester, but I asked the question early, and I said, and Kevin knows this too because he follows patients in clinics. The clinics, they receive information from us regarding what it is you are competent in. So obviously, you cannot provide ultrasound or do electric stim or biofeedback or put somebody on a mechanical traction or something like that because you have not been tested for competency. So as we go along through the semester, we inform the facilities. Okay, we just completed this competency, and now especially if you're in an outpatient facility, they can do electric stim. They can do this. They can do that. Right now, what is your competency? Competencies that you have are as far as transfers, right? You had a practical and transfer. That's about it right now, right? We did transfers, we did transfer training, muscles and all this other stuff, anything that you did last semester. So as we talk about things like we'll be doing soon, some wrapping, talking about PPE, sterile techniques, all that kind of stuff. So as we start to do that, you have a practical exam, then you'll be able to do that in clinics. So the clinics are advised of where you are in the curriculum, and initially they're given a sheet and said this is what the students have been competent in at this time. There are occasionally some clinics that become very overprotective and say, all right, I'm just going to have you stand by me. In that case, just let us know, and we'll, intervene and talk to the facilities because, as we said, we don't expect you to do everything because the bulk of not the bulk, but there's a lot of stuff that you're going to learn this semester as far as gait training. And as I said earlier, the gait training, the manual muscle test, the range of motion, the goniometry, the vascular disorders, all that kind of stuff is this semester, modality. And in the summer, it's going to be very different than it is now. But this gets you used to everything, and you will be allowed to do certain things, but not everything.
What about those special tests? I mean, we went over them through the last semester, but are we allowed to do all that?
There's no reason why you can't do special tests.
Okay.
Right. And generally what probably happens in clinic, and, we suggest it too, is let's do them with the therapy first, let's just, and when we go back to class on Monday, we're going to start with some of you probably know how to do it already, but we're going to do blood pressure and vital signs. So can you take a blood pressure on the patient? Casey, you probably can, right?
Yeah, sorry, could you repeat that?
I said you probably do blood pressure, right? With your degree?
I've learned how to do it. Yeah.
So after we teach you how to do it, we give you a practical on it. You're able, but certainly you can practice it with your clinical people.
Yeah.
Okay? All right, so we'll see you on Monday.